Bloomington School of Public Health in the Department of Health and Wellness Design. She earned her Ph.D. in clinical psychology with a concentration in neuropsychology from Nova Southeastern University in 2013. Through her work, Dr. Rodriguez aspires to contribute towards reducing health disparities among Hispanic older adults at risk for developing Alzheimer's disease and related dementias. Her research has focused on identifying cultural factors that contribute to cognitive decline, neurodegeneration, risk, and protection against developing ADRD and the caregiver experience among Hispanic families. She has studied neuroimaging measures to distinguish between dementia types and early prodromal stages of Alzheimer's disease and has examined the sensitivity and specificity of measures of cognition among Hispanic ADRD populations. Dr. Rodriguez has received state and federal funding for her research. She is a Butler Williams Scholar alumnus, which is a prestigious award from the National Institute of Aging, and a Research Education Corps Scholar with the Indiana Alzheimer's Disease Research Center. Her current projects focus on designing, evaluating, implementing, and disseminating culturally tailored interventions for Hispanic caregivers of persons with dementia. Through these works, she aspires to address a significant gap in ADRD research by seeking to understand a growing underserved minority population that is disproportionately affected and identifying interventions that will best meet their needs. Again, thank you so much, Dr. Rodriguez. It's so great to have you here.
Thank you so much for that wonderful introduction. I'm going to go ahead and share my screen. All right, great. Thank you so much for having me today in today's MAPP rounds. I'm excited to share a little bit about existing health disparities with Hispanics and white non-Hispanics in terms of Alzheimer's disease diagnosis and symptomatology. And then I'll share with you results of our research study where we examined a measure of clinical functioning and its relation to AD neuroimaging biomarkers. I don't have anything to disclose for this presentation. Objectives for today. I will first kind of briefly introduce or discuss some background information on some of these existing health disparities in ADRD diagnosis among Hispanic older adults. Share with you some evidence to support that there are differences in the experience of ADRD, especially in ADRD symptomatology and biomarkers between Hispanics and white non-Hispanics. Then I'll share with you the methodology and results of our study where we looked at a measure of clinical functioning and its associations to neuroimaging biomarkers. Then we'll discuss some conclusions and discussions. Okay, so if you don't know by now, the US population is becoming more and more ethnically diverse, and Hispanics are among the fastest growing ethnic group in the US. Currently, the Hispanics are the largest ethnic minority in the US with about, sorry, I can't see, about nearly 60 million Hispanics in the US population currently. And we're the second fastest growing population with growth between 2022, the Asian population demonstrated the biggest growth between those years, and the Hispanic population demonstrated a growth of about 80% between 2000 and 2022. So not only is the population becoming more and more diverse, we all know that the U.S. population is also aging with time, and the older adult population is also increasing. And underrepresented minorities such as Hispanics and African Americans experience the highest prevalence of ADRD diagnosis. Hispanics, about 12.2% of Hispanics have an ADRD diagnosis, and Blacks, African Americans, about 13.8%. But if you look at the chart to the right, you'll see that Hispanics are also projected to have increased prevalence, so the fastest and the highest increase in prevalence over time over the next 50 years. So this is a real public health issue. It's really important to identify factors that contribute towards the increased prevalence and the increased projected prevalence. And then there also exists a paradox where even though ADRD diagnosis is 1.5 times more prevalent in Hispanics when compared to white non-Hispanics, Hispanics are also more likely to receive delayed or missed ADRD diagnosis. So this is just a visual representation of data from a study conducted in 2021 with a health and retirement study data set. Where that just clearly demonstrates that Hispanics have higher proportions of missed and delayed diagnosis in primary care when compared to Blacks and white non-Hispanics. So really the question is, why is this? Why do these disparities exist? Why are Hispanics missing or not capturing? The ADRD diagnosis is not being captured early enough where treatment can be most effective. And there are various factors. Many of it can be explained by barriers to healthcare treatment. Hispanics experience disproportionate barriers to access to healthcare. They're more likely to be of low SES or be at the poverty level. They're more likely to not have health insurance. So that that's a barrier to getting them into the primary care office and getting diagnosed. And on top of that, knowledge is a barrier where Hispanics may not recognize cognitive impairment or memory problems as a symptom of concern or as something that needs to be seen by a doctor. Another possible explanation is, and one thing that we need to look at is, what are these common diagnostic tools that are used in primary care? And perhaps many of them aren't accurate, or they don't accurately capture ADRD diagnosis. And why don't they capture diagnosis? Because they may not accurately represent what's actually going on in the brain or represent AD biomarkers. Many of the tools used in primary care settings have validity based on Caucasian normative populations, which is not appropriate. We should really use tools that are normed with Hispanic populations so that we can make accurate interpretations about performance that you would expect from a Hispanic individual. And cultural factors can interfere with performance. One of the challenges that we face as neuropsychologists is that many of these neuropsychological tests and cognitive screeners, they were developed in the US, and they're culturally biased. They were based on concepts that are reflective of the US culture, that specifically that high achievement culture. So, it includes tasks like, for example, when you ask your patient to complete a test as fast as you can, that's a concept that, depending on the country of origin of the individual, may not be adequately received or interpreted. They're not used to doing things as fast as they can because it's just not consistent with their culture. So these factors just contribute into perhaps not having an accurate reflection of their actual performance when they're engaging in these tasks. And then, of course, there's language barriers. So you may have these tests available in Spanish, even with Spanish Hispanic norms, but if you don't, one of the needs and the disparities that are present in our system, in our healthcare system, is the lack of bilingual Spanish-speaking healthcare providers, psychometrists, neuropsychologists that can provide these tests and provide the accurate interpretation. Okay, so this, I just want to highlight this paper I co-authored. This is a systematic review of commonly used cognitive screeners, and this just kind of supports my point that the screeners, these diagnostic tools that are commonly used, may not be enough or accurate in identifying ADRD diagnosis and more specifically MCI diagnosis. Mild cognitive impairment, which is prodromal, identified as or considered a prodromal stage of Alzheimer's disease, and it's really important to identify tools that can capture those early stages of the disease so that preventative measures and treatments can be most effective. So if later on, this is just a snapshot of some of the the data that we presented in this review. So later on, you can go in and take a look at that in more detail. But essentially, the MMSE, which, as we know, is one of the most commonly used cognitive screeners. We have English and Spanish versions of that tool, but as you can see, there's very inadequate specificity to dementia diagnosis. Hold on, I'm going to drink some water. And then for the MMSE, sensitivity and specificity for MCI diagnosis is non-existent for the Spanish version. So the MOCA, this is the Montreal Cognitive Assessment, also very widely used. This is a much better tool to use for Hispanic Spanish speakers, with sensitivity and specificity for both MCI and dementia diagnoses. But it is sensitive to the effects of education. And there are some recommended education adjustments for those with less than 11 years of education. So there's a lot of factors, when using cognitive screeners to support ADRD diagnoses to consider, especially education level is one of them, with Hispanics really being less educated when compared to white non-Hispanics. So we were interested in seeing, what are some different tools outside of cognitive screening, which is now the most widely used diagnostic tool. How else can we assess ADRD symptomatology to help support our ADRD diagnoses? And we think part of the problem is ADRD symptomatology is different with Hispanics compared to white non-Hispanics. They don't recognize memory impairment, memory decline as something that's concerning, something that needs to be addressed by a healthcare professional. Almost 6 in 10 Hispanics report that they see memory decline as part of normal aging. Instead, what you find is Hispanics who carry an ADRD diagnosis experience more psychological symptoms, which is highly related to clinical functioning, and they're more likely to complain of difficulties with activities of daily living, especially in the earlier stages of the disease. So perhaps we should start looking at how do these symptoms, especially in clinical functioning and functioning with activities of daily living, how do they relate to AD biomarkers? And how can they perhaps improve or support an ADRD diagnosis early on in the progression of the disease? This is just a graph to support my point. It's a study that was conducted in 2020, comparing the presence of neuropsychiatric symptoms in Latinos versus non-Latino whites who carry a diagnosis of dementia, persons living with dementia. And you see across the board, Latinos experience more neuropsychiatric symptoms, and neuropsychiatric symptoms are directly related to clinical functioning. So what about Alzheimer's disease biomarkers? So this is a well-known model that sort of maps out what are the earliest biomarkers, the earliest signs of Alzheimer's disease. And then you see that amyloid, the accumulation of amyloid plaques that happens 20 to 30 years before diagnosis of dementia. And it can be identified, it can be captured either through CSF or amyloid PET scans. And those are the kind of the earliest indicators that are associated with the highest risk, biggest risk in developing developing an Alzheimer's disease-related dementia diagnosis. CSF tau is also an early indicator. And then you see measures of brain volume as measured by MRI or FDG PET, and cognitive impairment are kind of the last two. By the time a person presents with cognitive impairment, there's already been years of this accumulation of biomarkers. So we, as far as healthcare providers, those who are involved in diagnosis, we want to identify tools and measures that can capture these earliest signs of Alzheimer's disease, these biomarkers. So what does the literature say about neuroimaging biomarkers among Hispanics? We all know, accumulation of amyloid plaques in the brain is known AD neuropathology, one of the earliest signs of the disease. But much of what is known about these associations are from studies that have historically included predominantly non-Hispanic white samples. The few studies that have examined amyloid beta among Hispanics have demonstrated mixed findings. So there are some studies that compare Hispanics that carry a dementia diagnosis compared to white non-Hispanics, and they show that actually they have less amyloid beta in their brains when compared to white non-Hispanics. But there are other studies that don't show difference, that they don't really see that there's a difference between amyloid beta accumulation between the two ethnic groups, and there are a lot of factors. There's a lot more work that needs to be done in this area. I think one of them is country of origin, right? There are studies where the majority of their sample are of Mexican American origin. Some studies have a lot of Caribbeans in their sample, and I think that there are differences in the brain and AD neuropathology, depending on where a person is from or in their country of origin. And this next slide sort of demonstrates that as well. The genetic contributions, so the ApoE4 with the apolipoprotein allele with its 3 common alleles, E2, E3, and 4. These are consistently associated with increased risk of Alzheimer's disease. But when you look at studies examining Hispanics, it shows that Hispanic ADRD patients have that presence of the ApoE4 gene is less common, especially for those of Caribbean origins. And then when you compare the neuropathology or the associations of the ApoE4 with neuropathology, you see differences as well. So this graph that you see on this slide is from a study by Turney et al. In 2020, showing the default associations of ApoE4 and a default mode network in different regions of the brain. And you see that it's different, the people from different ethnic backgrounds just, have different brains. So I think overall, there's plenty of evidence to demonstrate that differences exist, kind of that the ADRD experience and associations to AD biomarkers. It's different when you look at it across ethnic groups. So what about clinical functioning? We know that greater functional impairment is associated with higher rates of progression to dementia. We know that Hispanics report complaints of problems with clinical functioning, problems with activities of daily living in the normal stages, and then in the MCI stages and the earliest stages of the disease. So we think that identifying sensitive functional measures that can detect early ADRD or can detect ADRD diagnosis early on in the progression can really go a long way for as far as prognosis and identifying preventative measures and treatments that can be most effective. So our study we aim to examine a sample of Hispanic and white non-Hispanic adults and identify relationships between functional impairment with MRI volumes, volumetric analyses, amyloid load is measured by PET scan, as well as amnestic and non-amnestic cognitive test performance. So given that I just presented all this evidence to support that these associations, differ between Hispanics and white non-Hispanic, we expected to kind of see the same thing. And we expected to see associations of functional impairment with especially the neuroimaging markers would be stronger among Hispanic older adults. And of course, controlling for those mediating factors, including age, education, and ApoE4 status. So our participants were recruited from the One Florida ADRC cohort. For those of you, who may not know, at the Alzheimer Disease Research Center, one Florida Alzheimer Disease Research Center, it's one of about 46 NIA-funded research centers across the country, with the goal of, just really examining and studying Alzheimer's disease. The one Florida ADRC cohort specifically is focused on ethnically diverse populations, and about half of their cohort identifies as Hispanic. I'm currently, I did this work when I was with one Florida ADRC. Currently, I'm at Indiana University, and I'm affiliated with the Indiana ADRC, but we continue to collaborate and work together and work on projects together. So the study again just demonstrates how ADRCs can work together and generate some good work. So inclusion-exclusion criteria, the participants to be included in the study had to be 60 to 90 years of age, have a minimum 6th grade education and reading level, identify English or Spanish as their primary language, had an available study partner. It was a study partner who completed the functional questionnaires. All the participants had an age and education corrected MOCA score of 20 or above. They need to be willing to complete functional assessment as kind of an additional assessment to the battery that they received with the ADRC. And of course, identify as Hispanic or non-Hispanic. So this is our, participant demographic. And we had 258 Hispanic participants, 203 white non-Hispanic participants. There were no differences in their age. Both groups were around 72, mean age of 72 years old. There were significant differences in education. This is consistent with what you see in ADRD research studies, where Hispanics were significantly less educated compared to white non-Hispanics. And then we had a mix of cognitively normal individuals, MCI diagnosis, dementia diagnosis, and again, similar to what you see in ADRD studies, there were more females, significantly more females in our samples when compared to males. So our functional measure was the Modified Clinical Dementia Rating Scale. This is a scale that was developed by the one Florida ADRC, specifically Mount Sinai Medical Center. And it's a modification of the Clinical Dementia Rating Scale, the CDR, which is one of the most widely used and commonly used measures of clinical functioning. And this table just shows the differences between the two, comparisons of the two. So the CDR has an open-ended informant interview format. And one of the key differences with the CDR and the MCDR is that they require a clinician. A clinician has to administer the CDR, whereas in the MCDR, we converted the questions into multiple choice format, and made it so that it can be easily administered by a non-clinician, like a trained psychometrist or a trained non-clinician. The same domains that are measured in the CDR are measured by the MCDR. So that's memory, orientation, judgment and problem solving, home and hobbies, community affairs, and personal care. And there's some differences in the scoring. So for the CDR, you get a score range from 0 to 3, and it's based on impairment, whether or not there's impairment in these domains. And again, it requires a clinician to kind of have that expert provide that judgment, clinically informed judgment, to determine impairment. Whereas in the MCDR, the domains are assessed by 6 questions, and where the respondent is asked to compare if there's been any change in clinical functioning previous to current performance. And then we get a range of scores from 0 to 2, again, determined on change, whether no change to like much worse. We did conduct sensitivity and specificity analyses on the MCDR. for both identifying both MCI diagnosis and dementia diagnosis. So we found that this tool was comparable, that there was still adequate sensitivity and specificity for MCI diagnosis among Hispanics. The sensitivity and specificity was stronger for non-Hispanic whites. But to identify dementia diagnoses, we found excellent, very, very, very high sensitivity and specificity for both groups. Reliability and validity measures demonstrated. We used the ADAS MCI ADL, which is another commonly used functional measure, in order to establish a conversion validity. And we found that there was a high degree of conversion validity between those two, with 56% shared variance. We also had our research assistants administer. We had 2 raters administer the MCDR at 2 different time points with about 4 weeks in between. And we measured inter-rater reliability, and we found that for both MCDR and the ADAS MCI ADL, there was moderate to good inter-rater reliability. So, we identified that MCDR was a valid and reliable tool to use for Hispanics. We do have, I forgot to mention, there's an English and a Spanish version. And the test was, the questionnaire was given either in English or Spanish, depending on the preference of the participant. All of our participants received neuropsychological battery as part of their ADRC participation. And for the purposes of this study, we looked specifically at the delayed recall measures measured by the HVLT revised and logical memory delayed recall from the WIMS-R, our letter fluency and category fluency, FAS, and animals, fruits, and vegetables. And then we had a trail making test part B as our measure of executive functioning. So just to compare scores between our 2 groups, this was kind of an interesting side finding, and consistent with what you see in the literature, where we had these Hispanics and non-Hispanics. They came to the study already carrying their diagnostic classification. So they carry the same diagnoses, or they're equally as cognitive normal MCI or dementia. But you saw some significant differences in their performance on these neuropsychological measures, and you saw that Hispanics performed significantly worse. So this kind of further supports our desire to, kind of find out what's going on. What maybe we should start looking at different ways to measure, or other tools that can further support diagnosis or further capture AD symptomatology. And then our AD biomarker measures, we had our neuroimaging markers, which were measured by MRI, volumetric analyses. And we had volumetric analysis of left and right thalamus, caudate, putamen, hippocampus, and the reflection of lateral and inferior lateral ventricles. We had MRI total intracranial volume. So what we did for this factor is we calculated a composite score, and we took the values of the volumetric analysis of those structures listed there, summed them up, and totaled them, and divided them by total intracranial volume to get a composite score. And then we had the PET SUVR centiloid score as our measure of amyloid load. And for our genetic biomarker, we identified the number of E4 alleles. So this table again compares Hispanic and white not Hispanic group to identify if there were any significant differences between the groups in terms of the presence of AD biomarkers, and we found that there were no significant differences, and they were pretty comparable between the 2 groups. As far as our statistical analysis, we use structural equation models, and for the Hispanic and the white non-Hispanic group separately. This is a multivariate statistical analysis. It's a combination of factor analysis and multiple regression, and it analyzes structural relationships between the measured variables and latent constructs. So the next slide, I'll show you how we created these latent constructs, and specifically, this analysis shows how these constructs are related to other constructs and tests, and additionally proposes causal relationships. So this is our SCM model: age, sex, years of education, total intracranial volume, E4 alleles, MRI regional volume, composite score, and our PET centiloid score. In the middle, those are our constructs. We had a functional limitations constructs, and then if you see to the right, those are the scores that went into our construct. So our functional limitation construct was composed of the scores on the different domains of the MCDR, those 6 domains of the MCDR, total scores for each one went into that construct. Memory was composed of our delayed recall measure scores. Letter fluency was scores for each individual letter, F, A, and S, category fluency for each category. And then we had our measure of executive functioning. We had our single measure. It's a trail making test B, which measures cognitive shifting and attention. So these are our results. So again, we did these analyses with white non-Hispanics and Hispanics separately, and we found that the associations, as you see on by the highlighted scores, differed. Like they weren't the same in the Hispanic group compared to white non-Hispanic. So whereas for both white non-Hispanic and Hispanics, MRI regional volume significantly predicted functional limitations. For the Hispanic group, the PET SUVR centiloid amyloid score was also a highly significant predictor of functional limitations at the 0.001 level. And then sex, to a lesser degree, at the 0.05 p level, was a significant predictor. And when we looked at the other factors, the other constructs, memory, the other constructs were mostly neuropsychological constructs: memory, letter fluency, category fluency, trails B. There were a lot of consistencies. There weren't really any differences. You know, both groups kind of demonstrated the same predictors for different areas of cognitive functioning. So really, the most salient differences that we found was in how these predictors were related to clinical functioning as measured by the MCDR. So in conclusion, our results indicated that among Hispanic participants, sex and amyloid load significantly predicted MCDR scores. MRI volume significantly predicted these MCDR scores for both groups. You know, so it indicates that perhaps functional measures like the MCDR may better correlate with amyloid load among Hispanics, which amyloid load is, as I discussed at the beginning of our presentation, it's one of those earliest signs of Alzheimer's disease. So, you know, what motivated us to do the study is to try and identify measures that can accurately reflect AD biomarkers among Hispanic or older adults in order to help reduce that disparity in accurate diagnosis, early diagnosis, and reduce the prevalence of delayed diagnosis among Hispanics. So perhaps using clinical measures like this MCDR can reduce those delayed diagnoses, capture ADRD-related changes among Hispanics at earlier stages of the disease when treatment can be most effective. And overall, it's important to remember cultural competence, the importance of cultural competence when making these diagnoses, when working with Hispanic patients. So not only understanding their culture, understanding their approach to test taking, to assessment, but also understand the relevance of clinical functioning as maybe a more salient sign of ADRD diagnosis and experience of ADRD for that population. So my acknowledgements that this work was supported by state funding from the Florida Department of Health and an Ethel Moore Alzheimer's disease program. And then I'd like to thank my wonderful multidisciplinary, multi-site team from the 148 ADRC. We have individuals from University of Miami, FIU, Indiana University, University of Florida, our data team. Without these individuals, the study wouldn't have been possible. So that's it. Welcome to take questions. I think that there were some questions in the comments.
Thank you so much, Dr. Rodriguez, for that great presentation. We do have several questions. I think we'll just go in order in which they were received. So one of the questions from the chat is, do Hispanics have cultural barriers in testing ADRD? For example, would they not want to know the results until like there's a therapeutic option for them?
I'm sorry, I was trying to read this question while you were saying it. Can you repeat?
Yeah,
I don't see it here.
The question
I
is
don't see it here.
within the webinar chat. Someone asked if there are any cultural barriers that Hispanics face in sort of testing for ADRDs. For example, would Hispanics generally not want to know what the results would be until there's actually a therapy for them?
Yeah, that's an interesting question. I mean, I think overall there is a stigma that exists with accepting Alzheimer's disease. You know, part of that knowledge gap of not recognizing memory symptoms as a problem and you know, as a cause for concern and as a prompt to go seek care there's a stigma, like they don't want to accept that their loved one is ill or has this devastating disease. So that is something that as clinicians and as healthcare providers, we need to take into consideration and especially as we approach providing these results and talking to them. And I think education has a lot to do with it, just providing them education in order to reduce that stigma and help them and giving them the tools that they need to provide the care. You know, because a lot of my work is also with caregivers, and that's a big issue is addressing these knowledge gaps, these stigmas experience, you know, across the family as a whole, and how that influence care and treatment for the patient as well.
There's also someone that raised their hand. I don't know if we can actually give them the function to speak, but if they wanted to type in their question within the Q&A, we'd be happy to answer that. Another one of the questions from the Q&A is pertaining to the study itself. Why the age range between like 60 to 90, and not like I guess like anyone younger or older?
Right. Well, at that age is when we expect to see, I guess, more significant decline in clinical functioning. That's when around that age range is when you expect to see ADRD diagnoses. You don't. I mean, yeah, there is a early onset Alzheimer's disease, which you see at younger age ranges, but that's more rare. So I think, you know, and that inclusion criteria, that's kind of wasn't my inclusion criteria presently. That's the age range that you see for ADRD or ADRCs across the country. Is, you know, they're really interested in capturing those symptoms when they start becoming more relevant. But there are studies out there. I know with the IADRC, there's a lead study. There are studies out there that focus more on those early onset patients and identifying, you know, what are factors that contribute.
I think pertaining to the prior question that you had answered regarding cultural barriers and testing in Hispanics, they had a follow-up question regarding whether are older adults okay for diagnosis, but it is the caregivers who don't want to know if their loved ones are getting ADRD, or maybe it's the other way around.
Yeah. Not necessarily, I think there's a lot of variability too. Sometimes there's issues in it with denial, right? And not like with the older adult patient not accepting their diagnosis and not understanding their diagnoses. So I really think there's a lot of variability, and across ethnic group, not necessarily with Hispanics on whether of how accepting that person will be with their diagnosis. And it also depends on how far along, like at what stage of the disease or the diagnosis recognized, I think might have play a big role in the acceptance of the diagnosis as well.
A different attending had a question. Have you looked at patients' health conditions like obesity, diabetes, chronic diseases that have higher risk to ADRD, and social connections like living alone, with a partner, or active in the community?
Yeah, I haven't looked at those factors in my research, but I know that there are things out there, obesity, cardiovascular disease, like diabetes, that is associated with an increase in ADRD. And the Hispanic population are actually more susceptible to those diseases as well. They have higher rates of cardiovascular disease. Social connections is also and I'm not extremely well versed in that literature, but that is also something that's interesting. And I know that there's stuff out there examining, social isolation is also being associated with cognitive decline.
Thank you. Someone had asked if you wouldn't mind talking about how long the patients needed to take in the neuropsych testing. Did they do them alone in the clinics? When they had questions on the test, could they ask easily? Did they have some training before the tests?
Okay. How long patients need to take neuropsych tests? Yeah. So typical neuropsychological battery is pretty long for older adults. We try to keep it as brief as possible. But 1.5 hours, is probably as short as we can keep it, because that we need to consider things like fatigue depending on the patient. But we can also break up the testing over 2 days. It doesn't have to all be done all in one sitting. The way do they do them alone? The way neuropsychological tests work is they're administered by either a psychometrist or a neuropsychologist. So it's not that they're sitting in a room alone filling out questionnaires or anything like that. And it's interactive, right? So they'll have them answer questions verbally, complete tasks, things, I don't know, manipulate objects. So it's very interactive. Most of the time, neuropsychological testing, especially in primary care, is conducted in the clinics. I know that there are a few, I think in academia and research, there's kind of a movement to take these tests to the home. I think that during COVID also that changed, like during COVID when everybody was in quarantine, and especially older adults were specifically susceptible or more susceptible to COVID and required to stay home. There's been more virtual, like virtual testings and abilities to telehealth. They use telehealth as a way to complete the tests in the home. Okay, when they have questions on the test, can they ask easily? Yes, they can ask, although psychometrists and the tester, the neuropsychologist, they're trained not to really manipulate the responses, as much as they can. They don't want anything that could probably affect the performance or result in an inaccurate performance or an inaccurate score. And then the question, do they have some training before the test? The patient themselves, no, they don't receive any training before the tests, but they get some orientation. The psychometrist or the tester will explain to them, what to expect. Hopefully that answers that question.
Thank you. Someone else in the chat had asked, do you see the differences among the sub-ethnicities of Hispanics, Mexicans, Cubans, Spanish? maybe that was pertaining to like when you were discussing the different demographics and differences between Hispanics and non-Hispanic whites. Um, uh,
Yeah, I mean, there's definitely differences in culture. Like I think the Mexican, Cuban, and Spanish culture, um, just in the way that they approach test taking, you can see those differences as a clinician. How did their attitude towards like healthcare professionals, for example, you know, some individuals are from certain regions that, you know, perhaps they experience more discrimination with the healthcare system, and they may have some biases or some, you know, sort of you know, it's just some attitudes that might interfere with effective testing and treatment. I don't know if that answers that question.
Thank you. Someone else had asked, how do you account for the results for letter fluency using FAS instead of something like PMR?
I'm not sure if I follow.
I think perhaps the individual might be referencing that uh, maybe like different normative reference groups. I know some of them include
Oh, I see.
PMR and some of them may include like FAS.
Okay.
Yep.
Yeah. Yes. Yeah. That's a good point. I mean, I think that would be something that we'd have to go back to our data and see if that accounts for any of the results or that affects any of the results.
Let's see. Someone else thanks you for the wonderful talk and asks if you have any suggestions on why sex and amyloid load are more associated with the modified CDR scores in the Hispanic population.
Right. Well, our, you know, of course, these are our study presented associations, so we can't really make any causal inferences, even though our analyses at least try to tap into that a little bit. Yes, but the hope is that perhaps these tests are more reflective of amyloid load sex. I mean, we do know that females have a higher prevalence of Alzheimer's disease when compared to males. So, you know, perhaps females also present with more functional impairments as well among Hispanics, or perhaps those effects are more sensitive among Hispanics as well. But, you know, we need more studies, more research to examine those associations further, those hypotheses further, and come up with more salient conclusions and results. Oh, I see. There's a comment here on Hi, George. Thank you. Not an actual question, but saludos from one of my previous students.
The next question is, what would be the next steps in research and in clinics to help Hispanics with ADRD?
I think that there's a lot of work to be done for research, and we need to just work hard on identifying more sensitive measures that can capture that AD neuropathology, more culturally appropriate measures and interventions. So much of the work that I do at IU is identifying culturally adapted and culturally appropriate interventions for dementia patients, for their caregivers. You know, the main study that I'm working on right now is providing this intervention to caregivers and patients to help reduce behavioral and psychological symptoms of dementia. So, like I presented in my slides, Hispanics who carry an AD or AD diagnosis, they tend to experience more psychological symptoms. So that not only is that associated with worse clinical functioning, but it also increases caregiver burden because the caregiver, on top of having to manage their loved one and their AD symptomatology, managing those psychological symptoms of things like aggression, depression, apathy, you know, anxiety when patient doesn't want to eat, you know, or want to take medication. Like those are among the most challenging symptoms, not just for the patient, but for the caregiver as well. So part of my work and my interest is to really push for identifying interventions that can be culturally appropriate and can take into consideration cultural factors that interfere with effectiveness of the intervention.
Next question is concerning the modified CDR, do you have study if they are biased due to characteristics of the caregiver?
That's not something that we have looked at specific to the MCDR, no. But yeah, interesting point.
And then the next person, have you looked at social determinant factors?
Social determinant factors in terms of clinical functioning? Yeah, I am currently working on a proposal to look at that a little bit more because yes, social determinants of health is a big factor that impacts not only clinical functioning but also access to healthcare, risk, highly associated with risk and protection against ADRD. So things like social economic status, immigration status, right? The stress that immigrants experience when coming to this country, acculturation, even other social determinants like I briefly mentioned discrimination in the healthcare system, and that can be a big barrier in accessing good healthcare and entrusting their healthcare providers and diagnosis and treating their disease. So that is something that I'm interested to look into a little bit more, and yeah, and hopefully, yeah, I can get more. We can get more information on that as well.
Thanks so much. Do you think that VR applications could break the Hispanic cultural barriers in diagnosis and interventions?
Like virtual reality applications, that's an interesting suggestion. Not really something that I've thought about. Yeah, I think there's a possibility, especially if the VR applications are created in a way that is culturally relevant and incorporates things from the Hispanic culture.
Great. See, I don't see any more questions. I actually had one. I was just curious when you had discussed some of the initial comparisons between Hispanic and non-Hispanic whites in terms of the cognitive testing. There was a difference initially in like the memory composites, where it looked like the non-Hispanic whites had scored a little bit higher. Do you happen to know if that was driven? Is the composite like both the HVLT and the WIMS are combined? And do you think that it was like maybe driven by one of them more than the other in terms of that difference that was initially captured?
But yes, the composite scores were the two tests combined. So you think that, yeah, so it would be interesting to look at those scores separately and see if there are maybe more differences in one versus the other.
Yeah, I guess
however, yeah, go ahead.
I was just like curious just because like sometimes like within neuropsych practice you do take a look at differences between like rote learning and contextualized learning, and maybe it might be associated with like certain cerebrovascular risk factors, right, that you had talked about in your talk. And so I was just wondering, like, could that initial difference be driven by one of those scores more than the other one? I don't know, thought it might be interesting to look at.
Right, yeah, I agree. I think that would be interesting to look at.
I don't see any other questions. There's just some like a discussion. Oh, the Eileen de Peña has raised her hand. Let me see. I think I can allow to talk. I think you should be allowed to talk now. Oh, okay. Thank you.
Okay. There is one more question here that I don't think we caught. I wonder which norms did your group use for the interpretation of the results of cognitive tests for Latino participants? We use Spanish norms, norms from that were conducted in other countries. Did you explore looking at other results of the UDS battery? Not in this particular study. No, we didn't. The naming test, language or visual spatial function. No, we didn't include those tests. Really, and really it's because we were trying to limit the number. We're trying to pick the most salient tests and limit the number of variables that we would include in our analyses. Because if we include too many variables, then that's gonna affect the strengths of the results.
There's one new question here that appeared. Would the time of diagnosis affect the results? Would the patients be tired in the afternoon?
Yes, I agree that the time of the diagnosis definitely would affect the results. And those are things that we have to take on an individual. We do our best to kind of do that on a case-by-case basis. And the psychometrists and the clinicians, they are trained to recognize signs of fatigue. And we'll accommodate the patient as best practices would be to accommodate the patient. And if they prefer to be tested in the morning because they're too tired in the afternoon or vice versa, yes, then we have training to be able to watch out for those factors and accommodate as necessary in order to just really best capture the accurate performance.
Okay. And just very quickly, it seems like the question was pertaining to PMR versus FAS. There seems to have been some discussion within the Q&A about how the ADRCs mostly don't use the PMR version. They still use the FAS with in-house norms for Spanish populations. So I think it just maybe pertains to the protocol that is being used with respect to which one is being used, either PMR or FAS.
Okay.
Thanks so much for that information, though. Okay. Thank you again, Dr. Rodriguez, for presenting. We're about 101, so I'm sure you might have other things to get to, but thanks so much for coming by and sharing your knowledge. I really enjoyed the presentation.
Thank you. Thank you for having me.